So what we'll be discussing here today is basically rewriting the guidelines in the management of diabetes and its complication by dapagliflozin. So we know we have this molecule which has been there for such a long time, and we are really lucky to use this. And as the use of dapagliflozin is increasing day by day, we are using it more and more. So we have this type 2 diabetes patient, a smoker, hypertensive, and dyslipidemia with an HbA1c of 8, LDL of 83, BMI of 32.5, BP 130/80 with a GFR of 72, which is a typical type 2 diabetes patient in our clinical practice. So, what is the atherosclerotic cardiovascular risk in this patient? Is he at some stage of heart failure? What renal sequelae can occur? So, almost 67% of Indian patients not reaching their HbA1c targets despite availability of metformin, sulfonylureas, pioglitazone, DPP4 inhibitors, GLP-1 receptor agonist, and insulin. Only 33% of our diabetic patient has an HbA1c of less than 7, and 62.5% of our diabetic patients were above the target of 180. If you look at the cardiorenal metabolic risk continuum, when can we intervene at this stage of disease to prevent further cardiorenal complication rather than treating them later? So this is again something which is very important. We need to understand that diabetes is something which is evolved with time. So we should intervene at this stage of disease to prevent further cardiorenal complication rather than treating them later. Window of opportunity for cardiorenal prevention in type 2 diabetes. The stage of left ventricular dysfunction or hypertrophy and the new onset albuminuria, especially microalbuminuria, is important. Heart failure or CKD are often the first manifestation of cardiorenal disease in type 2 diabetes patient rather than MI or stroke. First comorbidity identified in cardiovascular-free patients with type 2 diabetes. Compared with comorbidity-free patients in type 2 diabetes, cardiorenal disease was associated with a greater risk of mortality than stroke. Microalbuminuria, which occurs very early in diabetes, has similar risk of mortality like having a GFR of 40. So how do we place dapagliflozin in this subset of patient and provide a window of opportunity to prevent the cardiorenal risk metabolism continuism? So SGLT2 inhibition, there are definitely potential clinical benefits. There is reduction of microvascular morbidity, decrease in glucotoxicity, low risk of hypoglycemia. The ability to work at all stages of disease can be combined with other classes of antihyperglycemics. If you look at the osmotic diuresis, there is initial weight loss and decrease in blood pressure. Loss of excess calories in the urine, there is sustained weight loss and mitigation of weight loss from other class of antidiabetic. Dapagliflozin just doesn't work on the kidneys but have a favorable effect on the other components too via direct or indirect means. So we all know if you look at the omnious octet, it has some effects everywhere. So this chart is self-explanatory. We have SGLT2 effect which inhibits renal glucose reabsorption, increased lipid oxidation, decreased incretin effect, improved beta cell function, decreased glucagon secretion, increased EGP, that is the physiological range, and increases the insulin sensitivity. If you look at the glycemic efficacy of dapagliflozin, there is quick onset of action, sustained glycosuria for 2 years, 1.2% reduction in HbA1c by week 24. Gives HbA1c reduction when added to all OADs. There is multiple glycemic and extraglycemic benefits of dapagliflozin, as we have already discussed. And it is a molecule which is sustainable. So that is again very important. If you look at the different graphs, there is good sustainability proven over 4 years of treatment. Efficacy of dapagliflozin versus sitagliptin of cardiometabolic risk factors in Japanese patients with type 2 diabetes, a prospective randomized study, which is the diversity CVR. So DAPA DPP-4 inhibitors are neutral on MACE and heart failure outcomes in type 2 diabetes. And if you look at the snapshot of all non-insulin CVOTs till date, you'll find all the SGLT2 inhibitors are in the safe zone. So DECLARE TIMI 58 trial with dapagliflozin represents patients in typically primary care settings that we see in clinical daily practice where primary prevention of cardiorenal complication is the key. We had this elegant paper, pumps, pipes, and filtered dapagliflozin covers it's all, which went on to show that we need to target the larger subset of patients. And we have to target the so-called window of opportunity. DECLARE confirms the well-established safety profile of dapagliflozin in a broad cardiovascular risk patient. There is extensive safety experience in more than 17,000 patients studied for more than 4 years. Dapagliflozin is backed with a wealth of experience with over 2.5 million patients treated at more than 40 countries. So if you look at the story so far, management of blood glucose, avoidance of obesity, treatment of comorbidities like obesity, hypertension, use of SGLT2 inhibitors with caution as third, fourth line agents. If atherosclerotic cardiovascular disease, heart failure, CKD predominates, use SGLT2 after metformin. So the 21-22 guidelines incorporate latest evidence of SGLT2 inhibitor in high cardiovascular risk type 2 diabetes patient. If you look at the AD Association 2022 standards of care, the overall approach has been quite different. The patients are divided into two subsets where they establish atherosclerotic cardiovascular risk, CKD, or heart failure. And SGLT2 recommended independent of glycemic control in patients with high CV risk. ADA 2022 guideline evidence with different SGLT2 inhibitors. We have dapagliflozin, cana, and empagliflozin. That is something which is very important. Dapagliflozin has evidence across reduction in heart failure and CKD progression in CVOTs, primary renal outcome data, primary heart failure outcome data. Canagliflozin has studies across the heart failure and primary renal outcome data, and empagliflozin has studies across the primary heart failure outcome data and reduction in heart failure. We had different case scenarios where there was heart failure with reduced ejection fraction with worsening of renal function. We had this elderly gentleman with a high elevated NT-proBNP of 1900, type 2 diabetes with a UCR of 600. So they have a lot of end organ damage. If you look at the DAPA-HF, that is the first and the largest SGLT2 inhibitor heart failure with reduced ejection fraction trial to successfully improve outcome and symptoms. So almost 2373 patients were put on dapagliflozin and 2371 patients were put on placebo. Significant reduction in composite of CV deaths or worsening heart failure was noticed. And the effects were consistent across a broad and representative population. If you look at the comparison of endpoints of two trials of diabetes, which is again something which is very, very important. In the dapagliflozin study, which is the Emperor Reduce, there was non-significant reduction in all-cause mortality. Whereas in this, there was a significant 17% reduction. This is something which is more important. And if you look at the ejection fraction, with dapagliflozin, there was benefit across the spectrum of baseline LVEF. Whereas in empagliflozin, it was no benefit if the LVEF was between 30 to 40%. So these are again something which we need to understand and decide when we are using which molecule. So the standard treatment is beta blocker plus SGLT2 inhibitor now, followed by ARNIs, followed by MRS. So this definitely has changed. The treatment has evolved with time. The first treatment of patients with and without type 2 diabetes to improve cardiorenal outcome and reduce mortality. Dapagliflozin was well tolerated, keeping in its established safety profile, which was most important. And there was 39% risk reduction composite of sustained less than 50% GFR decline. So that is something which is very important. This is a molecule which worked wonders for the kidney as well. So there was 44% risk reduction in composite outcome of sustained more than 50% eGFR decline, ESRD or renal death. There was 29% risk reduction in cardiovascular death or heart failure, and 31% risk reduction in all-cause mortality. The trial was stopped early due to overwhelming efficacy. If you look at the 2020 KD treatment algorithm of type 2 diabetes and CKD, so if you are at SGLT2 inhibitor, if the GFR is less than 70, we do not discontinue. If the patient is on dialysis, we discontinue. So that is something which we need to understand. So declare DAPA-HF and DAPA-CKD3, very important study in different subset of patients. One in atherosclerotic heart failure, the other in heart failure with reduced ejection fraction, and the other in CKD. So that is something which we need to understand. So how can we ensure better efficacy or outcome? Choosing the innovator and the research agent. We all know there is a concept of crystalline versus amorphous. Crystalline is pure as compared to amorphous. It is more stable, and at higher temperature, increased relative humidity, amorphous dapagliflozin is not stable, and its recrystallization and chemical degradation may occur, resulting in lower efficacy. Thank you all for your patient hearing. I think if there are any questions, I'll be more than happy to answer.